Greetings, everybody, and welcome to the California Advancing and Innovation Medi-Cal CalAIM Renewal Explained webinar. I am Christina Zuniga, Senior Program Manager with Health Leads, and I will be your moderator for today's webinar. We will begin on time as we only have 1 hour for this conversation. Next slide, please. There will be live Spanish interpretation available. Para escuchar este seminario web en español, haga clic en el icono de interpretación del globo terráqueo y seleccione su idioma. Y para activar los subtítulos, haga clic en el icono de subtítulos y seleccione mostrar subtítulos. Aquí hay una fotito donde pueden ver cómo seleccionar esas 2 opciones. Y nuestros intérpretes es Javier y Gabriela. Today's webinar will unpack California's upcoming 1115 and 1915B waiver renewal and what it means for providers, community health workers, and the communities that they serve. You'll hear from our guest speaker, Melora Simon, who will provide an overview of the CalAIM waiver renewal process. You will also hear from 2 panelists, Anwar Zuhidi from Partners in Care Foundation, and Kitty Bailey from the San Diego Wellness Collaborative on how CalAIM is advancing health equity, where improvements are still needed, and strategies for sustaining programs amid budget constraints. Finally, you, the audience, will be provided with an opportunity to ask questions to our speakers and panelists. Please make sure to use the question feature box provided. Feel free to drop questions throughout the presentation and dialogue, as we will address those later today. Next slide. Now, before we begin, we want to acknowledge that we are on native land. Please use the QR code to find the land you are in, should you need it. And in the chat, please introduce yourself, your location, name the indigenous nation whose land you live in, and share anything you want to say about how you acknowledge and or take action to honor the land of the people. I am currently in Mexico City, formerly known as Tenochtitlan, Mexica, and I always just learn the history and making sure that I'm honoring my ancestors. And lastly, I will share our practice agreements that you see here on the screen. Please keep these agreements in mind as we spend our next hour together. Please be present, brave, and curious. Create an inclusive space. Invite anti-racist dialogue. And be accountable. Now, this is our full team here under the CHWPR Amplifying Initiative Impact, Cedars-Sinai, CHCF, Health Leads, BRG, here on the screen that make it all the magic happen. Now, without further ado, I would like to introduce you to our speaker, Melora Simon, Associate Director at the California Health Foundation, where her work focuses on advancing person-centered care for people with complex needs. Her roots are in managed care, and then you will see the other 2 panelists on here who will be then responding to questions and reactions to the presentation. I'm going to now pass it on to you, Melora.
Thanks so much. It's great to be here. So we can move to the second slide, not the cover, but the one ahead. Thanks. So I wanted to start just by sharing kind of a little bit of what we're hoping to do today. So the first is just talk about how CalAIM connects to the community-connected workforce and how important the community-connected workforce is to CalAIM and to equity in CalAIM. Secondly, we wanted to just give an overview of what to expect and what to watch in terms of the CalAIM waiver renewal process. And then finally, we wanted to kind of take stock of where we are. What are we hearing at this point in implementation from both patients and providers? And what does that mean for the future? And that's what we'll do in the panel as well. Next slide. To orient you all, there are going to be four main sources that I'm pulling from as I do this presentation. So the first is a set of in-depth conversations we had with about 150 Californians with complex needs and their caregivers. And we didn't specifically ask them about CalAIM. We asked them about what they needed and what their experiences of care were. And I think it's really, really helpful to kind of ground the work in those experiences and needs. Um, Secondly, I'm going to draw, kind of moving around the clock face, I'm going to draw from a presentation from the Center for Healthcare Strategies, which looks at CalAIM and puts it in the national context and the federal context, and kind of gives us a sense of what to expect in terms of renewal. I'm also going to highlight some data that the Department of Healthcare Services has shared about uptake of ECM, Enhanced Care Management, and community supports through the end of 2024. And then finally, I'm going to draw from a statewide survey that we did in both 2023 and 2024 of more than 1,000 implementers of CalAIM, folks like you who are on the webinar. And we have a specific deep dive into the community-connected workforce that I'll also draw from. So just wanted to orient you since we're going to pull in from a bunch of different sources. Next slide. So let's start with a community-connected workforce and CHWs. And what we learned from our provider survey, that last source I talked about, is that CHWs are critical to the equitable and effective implementation of CalAIM. So more than 2/3, 68% of leaders that we surveyed are using CHWs, promotores, representatives in their workforce as part of their CalAIM implementation. And they really value the connection, the ability to reach, the capacity, and the effect that they have on outcomes and on equity. So you can't kind of understate how important the community-connected workforce is to CalAIM. Next slide. So let's move to that second objective, which is just what to expect and what to watch for as CalAIM goes into the renewal process. So the two waivers that CalAIM is authorized under both expire at the end of 2026. And the Department of Healthcare Services has already started to make plans to ensure that these kind of vital services are going to continue to be available. So this past July, they released a concept paper and asserted that actually a waiver is not needed for 12 of the 14 community supports, essentially all the ones that don't include room and board, so everything except for medical respite and post-hospitalization short-term housing. And that ECM is authorized under federal Medicaid managed care regulations. And so neither 1115 nor 1915 is actually required for California to operate ECM. So I think that many of you who feel like there's optimism that CalAIM is going to continue, but maybe change a little bit, can kind of look at that and kind of take heart from the fact that a waiver is not needed. In addition, many states across the political spectrum are using these approaches too. So it would be very difficult for the federal government to single out California. Doesn't mean it won't happen. There's definitely a target on our back, but it would be legally difficult. And then finally, DHCS has shown cost effectiveness and positive outcomes, both for ECM and its precursor program, Health Homes, and for 12 of the 14 community supports. And that's something that the federal government is going to be looking for as they're thinking about renewal. So while there is uncertainty, there's a lot of reason for optimism. And it's great to see that a lot of you are kind of thinking about that and understanding that going into this, this cycle. Next slide. So let's talk a little bit about kind of where we are with CalAIM and what's been happening. And I wanted to start with people with complex needs themselves and kind of what they said they want and need when we spoke to them. And so there's 6 findings, and the first 3 are on this slide. And the first thing that we found is that people don't fit particularly neatly into a single population of focus. There is a lot of overlap and intersectionality between the needs that people have, and that can sometimes make it difficult for kind of how they fit into CalAIM. The second and most foundational is that trust in providers is really, really critical. And participants in our research really, really value culturally resonant care and providers that show up with empathy and with fairness, and that show up with life experience and with a background and set of experiences that look and feel like theirs. Third finding is that care management is absolutely essential to navigating our very, 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 very complex system. And that was particularly true for people with language barriers or with limited digital literacy. Next slide. However, care management is essential and necessary, but it's not sufficient. So when we talk to people, they over and over said that basic needs like housing, food, and employment often take priority over health concerns. And when the health system kind of puts its goals over what people really want and need, it can be really, really tough to engage them. And so it's super important as we're out in the world that we listen to people's goals. And one of the reasons that people loved having care managers with lived experience was that they did that. The fifth was that people really, really want integrated care. They want one-stop shopping. Once they find a provider that they trust and that they built a relationship with, like their wish is that more services were provided by that organization so that they don't have to retell their story. They don't have to reestablish that trust. And then finally, participants continue to face really, really strong barriers to care, long wait times, limited access, not available in their area. And this is particularly true for mental health services and for dental health services. So this is just kind of, I think it reinforces the need for enhanced care management and community supports. And it gives us a little bit of a flavor of, as we're thinking about implementation and thinking about kind of how to show up for people, this is what they're looking for. Next slide. So let's look into the data a little bit, and we'll start with enhanced care management, or ECM. As we look across different communities, different plans, we see that fewer than half of plans are at or above this target of 1.5% of Medi-Cal enrollees. That actually forms the basis for what managed care plans are being paid for in terms of ECM. So there's a lot of variation, and those kind of just under half plans only represent about 36% of enrolled lives. They're not necessarily the biggest plans. And if you actually go down to, many managed care plans have multiple counties. So if you look at this at the county level, at the community level, less than a third of these managed care plans are actually at that goal of 1.5%. So ECM has not penetrated as deeply into communities as we'd like to see it, or as plans are being paid for. So there's a real opportunity there. Next slide. When we talk to providers about ECM, while they definitely cite successes, they also talk about how challenging it is and how difficult implementation has been. And the three biggest challenges that they talk about are payment, different requirements from different plans, and then the challenge of the workforce feeling tapped out and overwhelmed. Next slide. Turning to community supports, and again, here we're looking at some data from DHCS. We're seeing that the optional nature of them has really been a barrier to access. So utilization is incredibly concentrated in just 3 supports. So more than half, 56% of the community supports that were offered in 2024 were medically tailored meals. Following that is housing transition navigation at about a quarter, and housing tenancy sustaining at 9%. So the remaining 11 community supports combined accounted for only 11% of utilization. So it's really concentrated in just three services. In addition, it's also really concentrated in plans. So just 3 plans accounted for almost 40% of the utilization, and they're not the biggest plans. Those 3 plans are only 15% of Medi-Cal enrollments. And when you kind of really dig into the data, the optionality of community supports is an issue. So first, plans have to decide to offer the community support, which is not universal. Second, they build a network of providers that actually have the capacity to deliver it. And then finally, they have to authorize the support. And so when we look across the state, only the housing trio, which is housing transition navigation, housing deposits, and tenancy sustaining services, that's the only one that's universal across all counties. And even then, offering a support doesn't always translate to people getting it. So if you look at the county level, more than a third of plans offering a support had 0 utilization. So no members using that service in the last quarter of 2024. And 28% had utilization by fewer than 11 members. So that means that even though a lot of plans are saying that they're offering it, it's not getting to people, or it's getting to very, very, very few people. So this is a real challenge with community supports. Next slide. When we talk to providers, we see many of the same challenges around payment, plan requirements, and workforce. Next slide. There is a real bright spot, and I'm going to not spend a lot of time in this slide in the interest of time. But when we look specifically at ECM and the community supports that are focused on people experiencing homelessness, which is one of the few populations where we have a denominator, right? We have a sense of how many of them there are. If we compare how many people are getting the services to how many people who are likely eligible for the services, we're seeing real progress. So, between 2023 and 2024, we went from about 20% of people receiving ECM to almost 40%, so almost a doubling. And similar traction on some of the other services. So that's a real bright spot in CalAIM implementation. And similarly, when we talk to homeless service providers, we hear a slightly different story than when we talk to other providers. So 84% say that CalAIM has actually improved their ability to manage the comprehensive needs of the people to serve, that integrated care that we heard people ask for. They have the same challenges around payment rates, but there's a lot of commitment to growth and a lot of optimism about the future. Even housing developers, affordable housing developers, actually see ECM and community supports as a way to fund the services in permanent supportive housing so that the funds for the housing itself can go further and they can build more housing. But we do see some troubling signs in the early 2025. 2025 data isn't available, but when you look at the fourth quarter of 2024, we do see that plans are starting to pull back on community supports. So there's some concern about whether even these bright spots are going to continue. Next slide. When it comes to equity in CalAIM, we don't have particularly great data. We can look at how the use of ECM and community supports compares to the use in the overall population. And we see that white, Black, and American Indian, Alaska Native enrollees are overrepresented in their utilization of ECM and community supports, while Hispanic or Latinx and Asian Pacific Islander enrollees are underrepresented. But we don't have data on eligibility for these services by race and ethnicity. So it's very difficult to know whether the utilization is equitable. Similarly, people with English as their primary spoken language are overrepresented in the utilization of ECM and community supports, while Spanish, Cantonese, and other are underrepresented. So that's a troubling sign in terms of equity. But again, we don't have a sense of the number of people who are eligible by primary spoken language. So it's very difficult to tell or to hold plans accountable. Next slide. So looking ahead, there's some open questions. There's some uncertainty. We don't know how the bill that passed Congress in the summer, HR 1, will be implemented and how California will respond both to work requirements, but also to the scaling back of provider taxes, which is one of the big sources of the budget for the Medicaid program. We also don't know whether new guidance will be issued by CMS between now and waiver renewal that might make it more difficult to continue ECM and community supports. And we also don't know how the uncertainty in the market is translating to impacts for providers and patients, right? We see that plans are pulling back a little bit, but one of the reasons I'm really excited to have the panel is to hear kind of how folks that are closer to the ground are seeing that uncertainty play out. So I'll turn it back over to Christina for that panel.
Thank you, Melora, for an insightful presentation. Now you will hear from Anwar and Kitty, who will share their experiences and perspectives on the ground regarding CalAIM Renewal implementation challenges, suggestions for improvements, and their hopes for the future of CalAIM. I will now have Kitty introduce herself and then Anwar. So Kitty.
Hi, everyone. I'm Kitty Bailey. I'm the CEO of the San Diego Wellness Collaborative, and we operate Neighborhood Networks, which is a Medi-Cal community care hub, which means we hold the contracts for enhanced care management, the community supports housing trio, and community health workers. And then we have a network of 12 community-based organization partners who together have over 80 community-connected workforce, serving 1,000 housing navigation clients, 700 ECM clients, and over 1,500 community health worker clients. And we're doing this both in San Diego and Imperial counties. So I'm really pleased to be here, and I really thank Health Leads and California Healthcare Foundation for making this time available.
Thank you, Kitty. Anwar?
Here we go. Morning, everyone. My name is Anwar Esquehed. I'm the Vice President and Chief Strategy Officer here at Partners in Care Foundation. We are a large CalAIM and enhanced care management and community supports provider, along with a waiver provider for the State Department of Healthcare Services. We are also transitions of care management provider privately with hospitals and also with CalAIM. We too have a large community care hub statewide, doing a lot of CalAIM work and also private work directly with the hospitals. I believe we have served over 10,000 lives in last fiscal year, and we're aiming to increase the size of the folks that we are serving based on the need. Really happy to be here. Really excited about this webinar. So thank you.
Thank you. So now let's dive into our first question and pick up where we left off. And so Anwar, I will have you kick us off with this first question. In what ways is the uncertainty impacting Medi-Cal providers and participants and our community members?
Oh, thank you for that. I want to piggyback on what Melora said. I personally am very optimistic about CalAIM. I know there's going to be some changes, and I know that is a risk for CalAIM providers and also for the state and our community. So because of that, regardless of my optimism, we are working, the executive team at Partners in Care is working diligently with our board also to diversify our offerings. And that really includes working under Medicare, duals, DSNPs, commercial hospitals, and other federal opportunities. And that's what the agency is doing right now. But in terms of participants, we've been hearing a lot of concerns, especially, unfortunately, among the immigrant population, trying to really help them understand and really work with them so that they feel safe. Unfortunately, we have been seeing a lot of immigrant families asking us not to do home visits and to keep it telephonic. And that's kind of been a little burden on us. And we try to make sure that they understand that we are in no part sharing any information or will be sharing any information so that they're safe. We are also working with them. I know there's a big risk in terms of the redetermination. The federal Medicaid work requirements really present a significant challenge right now, specifically in minimizing the coverage disruptions for eligible members. So we were being proactive. We reached out to the state. We were definitely reaching out to all the health plans. How can we get ahead of this? How can we start planning so that there is really no disruption and we could really help our population stay covered and stay healthy. Thank you.
Thank you, Anwar.
Mhm.
Kitty?
Well, yeah, I just want to echo everything Anwar said. We definitely see the impact of the ICE raids. Folks are not wanting to leave home, not wanting to go to the grocery store, not wanting to come meet with their lead care managers. And so that is definitely having a very real impact as we speak today. So I wanted to echo that one. Also, just reemphasize everything Anwar said around the upcoming changes in Medi-Cal work requirements and redeterminations. And we're really looking, our community-based organization partners and really all of the community in San Diego, we're really looking at this as a time to come together and collaborate on solutions that we can ensure Medi-Cal members can stay enrolled. We think that the community connected workforce are going to be critically important in helping members stay enrolled. And for those of you on the call that are in San Diego, if you want to come to the Live Well San Diego Advance on October 22nd, we're going to hold a session to really kick off a community-wide conversation about it, how we can work together to really minimize the number of Medi-Cal members impacted negatively by losing their Medi-Cal coverage. We're going to have a big conversation around that. So look forward to seeing many of you there.
Thank you, Kitty. Melora spoke to some of the challenges of CalAIM implementation. How do these show up for you, Kitty?
Oh, the challenges. Okay, well, I have a list. So let me see, and then Anwar can build on my list. I'll start off. Well, this has been well documented, especially through the work California Healthcare Foundation has done to survey those of us that have taken these CalAIM contracts. So we have the basics of the challenges with claims, contract administration, the challenges of working with multiple health plans who all have created different sets of portals, assessments, rules and requirements. All of these things have really created challenges. One of the most timely challenges that just came up recently, that's a great example of how hard it is to do CalAIM, is we saw a change in the way housing deposits could be used. So they could no longer be used for first and last month's rent, effective, I think it might have been like July 1st. We didn't find out about it though until like July 7th. So the rollout of that change was really challenging for us because we already had conversations going with our clients and through our housing navigators. So those kind of administrative changes create a tremendous amount of burden on provider groups. We're also extremely challenged by the upfront cash requirements for housing deposits and the lack of an administrative fee on housing deposits. We have done over 350 housing deposits alone at neighborhood networks this year. And it's really been just a community investment we've made in doing this because there is no reimbursement for these housing deposits. And then some of our other partners around the state, we know they've seen changes in the eligibility criteria all of a sudden. For example, we have a great partnership with a medically tailored meals provider up north, and all of a sudden there were all these new eligibility requirements being placed, which severely impacted potentially was going to impact caseloads, which would then have a financial impact. And they were able to work that out, but it was sort of only after many conversations with the health plans. I'm going to limit myself to one more. Two more. I'm going to mention transitional rent, which is coming, which I think all of us feel very unprepared for. And yet we think many of our clients are likely going to be eligible for. And then the last one, which is sort of a broader concern, is we really believe that the goals of CalAIM around health equity are best delivered through the community-based organizations all over the state. And we feel like there's an unequal playing field with for-profits that has happened, that has been created. And we really feel like that needs to be addressed through some state rules, guidance, approaches. So that was my list.
Perfect. Thank you, Kitty. Anwar, what is your perspective on some of the biggest challenges?
I'd like to say it's identical 100% to what Kitty said, so it makes me answering this question easier. And it's interesting that Kitty brought up the for-profits because that is quite a buzz in Sacramento right now. It's interesting to see how that folds out. Just want to emphasize a little bit more in terms of the different requirements and the reports going to plans. I'm happy to say that with our work, with the plans, but also with the state, they seem to be less than it was before, but still, there's a lot of different requirements, making us have to have a team that specializes for this health plan and a team that specializes for another one. And we are a large CalAIM providers with many health plans, and it makes it a little bit difficult, and it causes non-reimbursable administrative burdens. And that's been our experience right now. In terms of the payment delays, that has been one of our biggest pain points, not only for our agency, but keep in mind we have over 75 community care hub providers under our umbrella statewide, and we have to subsidize the health plans, and because we have to pay the CBOs, but you could see sometimes delay for us becomes a delay for them, although we are not doing that anymore. We are now just paying them regardless of the health plans. That too, by the way, has improved tremendously. There are still some delays with some health plans, but it has definitely improved.
Perfect. Thank you both for such insights. Now let's talk about your hopes for the future, and what improvements do you hope will be in the CalAIM renewal process? Kitty, you can kick us off.
Okay, well, I'm going to just mention one or two and then really let Anwar jump in here. So we both, I know Anwar and I both want to call out that we're really looking forward to Department of Healthcare Services really releasing more and more information on Medi-Cal community care hubs. So they now have a website with a toolkit, and we know that toolkit will be getting more robust. They've recently got a draft document they've put out to the field, because I know both of our organizations are hubs, and we really believe that hubs are a great solution to help CBOs participate fully in CalAIM. So I'll pause there and let Anwar take this one a little bit more, and then round back to me maybe or see questions.
Awesome. And Kitty did reach out to us right when the state released that. Her and our agency were invited to provide feedback. So really excited to see this. We have been working on the community care hub model for many, many, many years. Our founder and president, CEO, June Simmons, has been leading this nationwide. And we started our community care hub, boy, when was it? 2016 maybe? And it wasn't really adopted, not only by CBOs, but also by health plans. And even the state didn't really know much about it. And a lot of the health plans would put out the sign or just scream, no, this is delegation. Now you have to have a delegation. It's really not. It's not like the physician groups, the delegation that way. It's really a unique opportunity that both Kitty and our agency have discovered to allow CBOs to work under CalAIM without the administrative burden that comes along with the contracting with the health plans. Now, both of our agencies are advanced enough to handle this. We've been working on it for many, many, many years. And this way we could bring the CBOs and increase utilization of CalAIM under our umbrella, under our quality assurance programs, under our insurance, under our accreditation, in order, and of course, training, in order for CBOs to be able to step up and help their community. We don't want to open up a partners in care in some county that we don't know. There's been CBOs there for decades. We want to leverage them and make sure that they are, and CBOs have the opportunity to say, okay, I know enough about CalAIM and I build my reserve. Now it's time for me to flourish and sign up directly with the health plan, and they have every opportunity to do that. They're not stuck with us. It's just an option. And we see healthier communities, and we even see happy health plans because they're getting consistent care plans and reports and encounter data from our community care hubs, both Kitty and I's, whereas where you see other different CBOs providing different types of encounter data. So it brings consistency. And this is not only for enhanced care management, this is also for community services and also for CHW services, transitions of care and working directly with hospitals. So we're really excited about that.
Yeah, perfect. Just I know this question wasn't on there, but just wanted your quick thoughts around just the roles and the futures for CHW PRs and kind of, in the work. So just curious if you have any additional thoughts.
I mean, I think I just got off a call this morning where we were talking about how critical the CHW workforce is going to be when we move into 2027, and how, while we can't bill for enrolling folks in Medi-Cal for the first time, once folks are enrolled in Medi-Cal, being able to stay engaged in benefits, including Medi-Cal itself, but also including SNAP, and other benefits that we know might be also being impacted, are really going to be a key role. So we're really going to be looking at pivoting our CHW resources, case management system, training, to really help support this workforce in being those community connectors into the benefits and helping navigate those benefits and helping be able to navigate the work requirements. We know that work requirements, it's not just a one size fits all. You either can maybe be exempt from them, or there's various ways to meet them: education, volunteerism, working, and navigating all of those different ways that you can meet those work requirements, getting the documentation, staying on track for submitting. We feel like the CHWs are going to be such a critical component of keeping folks engaged in Medi-Cal. The state has sort of outlined a worst case scenario where 3.4 million people lose their Medi-Cal benefit because of the work requirements. And I say, no way. That's like 70% of the adults that are going to be required to meet the work requirement. I say, no way. I say we have a goal of 0% of those folks losing Medi-Cal because they can't meet the requirement. And that it's really, this is the CHW's role to help make this happen for us to meet this big goal.
I love it. I love it. I want to remind everyone, and Kitty also was part of this, how much we all worked on to try to make the CHW contracts work. For over a year, it didn't work. The state was concerned, the health plans were concerned, and we were just trying to innovate the heck out of this. And we finally figured it out, and we're finally doing it. And I'm happy to report that our CHW work is very diverse. We're leveraging it for transitions of care services in the hospitals and the hospital will help with, or the CHW would help with the discharges and then form handoff to ECM if they qualify, or other community support services. We're going to be leveraging them for the redetermination, for central intake. Look at all the things that the CBOs have been doing for decades, and they have not been paid. And now all this work that is directly with members is now being reimbursed by the CHW contract. And we're using it for pre and post ECM. That was an idea that one of our colleagues, Rafi at LA Care, had mentioned. And we're also innovating with the DSNP population. We're using community health workers to do HRAs, and that is a health net innovation, and happy to be working with them on that. So let's keep on innovating, because I agree with Kitty. CHW is really kind of the future of all things CalAIM. So I'm really excited about that.
Perfect. Thank you both so much. I know there's a lot of good questions on the chat, and so I just want to remind folks to please put it into the webinar question box. We'll be reading those questions and comments directly from there. And so again, thank you both, Kitty and Anwar, for sharing your perspectives and experiences with us. We're now going to open the Q&A. I'm going to be reading questions and comments from the box. And so Melora, Kitty, and Anwar, please feel free to jump in and answer any of the questions that resonate with you. I will start with the first question. Okay, what state legislative and budget actions would be necessary to continue the ECM CS permitted programs should the waiver renewal be rejected?
I'm happy to take that one, and just to say, like, that's above my pay grade. I don't know. I think that, if things are rejected, it probably will have meant that there's been some changes in regulations on the federal side. And so without knowing what those changes are, it's difficult to ascertain what the state would need to do. So I think it's a really important area to watch, but it's difficult to say right now with any certainty what would be needed.
I'll just add on a little bit from the way I'm looking at it. Just remember, from what the state is telling us today, they are not going to be applying for a waiver for ECM and 12 of the community supports. The only waiver that's going in is for the 2 room and board community supports. And if those do not get approved, I do think there's a plan B that might be possible using the transitional rent waiver, which is approved and was only recently approved, which means we have it for the next 5 years. And room and board can be covered under transitional rent. And so there's a whole approach to combining the transitional rent payments with those other short-term housing payments that are currently covered under the waivers and may or may not get approved. It's very in the weeds.
Thank you. Anything for you, Anwar? Thank you both. Okay, next question. Are there similar community-wide efforts in LA County to identify solutions for keeping Medi-Cal members covered and avoid disruptions?
I can start that. I know that there's been different talks with community providers, with the health plans, with county officials and area agencies on aging in Los Angeles. Nothing concrete, no scope has been determined yet, but we're trying to figure out what the county could do, what we can do, what our CBOs under our community care hub could do, what CBOs could do independent of us, in order to really implement one of these ideas, to be a bit proactive and make sure that people do not lose their coverage, because we feel like there is a huge risk of people losing their coverage based on the redetermination requirements. And some of them are not used to this because they were enrolled during COVID and the requirement of renewal was waived.
Thank you, Anwar. Anyone else? Next question. Are there any practical models of blending Medicare services with CBO CalAIM providers? CHW support cannot be billed directly, to my understanding.
That I can start with that. I love blending and braiding programs, even pre-CalAIM, one of our sweet spots. There's so many opportunities. Community health worker contract cannot be blended with waiver programs like MSSP and HCBA and enhanced care management. But it can with other services, including private duty, including housing. housing is a little tricky because you cannot duplicate the case management, but there's so many other ways to blend and braid these programs together, including ECM with community supports programs. The opportunities are really based on the care management requirements that person, that member would need. Mhm.
Thank you, Anwar.
I think that whoever asked that question, I think a place to start is probably the Medicare community care codes, which are specifically designed for CHWs in collaboration with a clinical setting. So it does require building the relationships between the CBO and a clinical partner so that you really integrate a CHW onto the care team, which you can do as a CBO and a clinic can get together, partner, and really figure out a way to integrate that CHW onto the clinical care team while still being employed by the CBO. And then you can work out who's going to actually bill the G codes to Medicare. So I know that was kind of a wonky answer. I know Anwar's organization has a whole slide deck about doing this that I've seen June present on. So it's kind of one of the easy paths, I think. Partners in Care Foundation is like the OG in this world of using Medicare contracts and then layering in the Medicaid contracts. So we really look to their expertise.
Okay. Thank you. Okay, next question. In San Francisco, FQHC PCP clinics are receiving favorable priority for members, no matter the member request for ECM assignment. How is DHCS dealing with unfair practices?
So this one gets me excited. So we are currently experiencing something similar to this, where we will get a client reaching out to us and telling us they want to have ECM, but indeed they already have ECM and they're assigned to another ECM provider, but they would prefer to come and receive ECM services through our neighborhood networks. And this has been a real challenge. I think this is an opportunity for improvement. What we have experienced lately is that the current ECM provider has to proactively inform the plan that they no longer will be enrolling this client in their ECM program, which is unlike anything else. Because normally when a member calls their health plan and says, hey, I want to change my PCP or I want to have a new provider, that's all it takes is the member's stated preference. And we have not been seeing that being honored by the health plans. We've actually been held up by waiting on a letter from the current ECM provider disenrolling the person, which is problematic. And so we are working very hard on this right now to get the health plans to update. I do think this is a process and policy level change that we can work with our MCPs on. One by one to inform them that this is happening and get them to change their internal policies. This isn't one I would necessarily yet escalate to DHCS. But I'm interested what Anwar's experience, if he's having experience with this.
Oh, we started working with a path-cited provider for this is a couple of years ago for transitions of care services from the hospital to ECM. And boy, did we encounter a lot of this. And we have informed DHCS. We're very we just have to. Some health plans are actually taking the member's word and saying, okay, we will disenroll you. They will then send a notification to the CBO saying this person is now disenrolling and transferring to another. But there has been, like Kitty mentioned, several other health plans saying, no, it has to be the CBO. So we would then call them. And that would be that type of coordination has historically been not reimbursable, but now we're going to be leveraging the CHW contract in order for us to get paid for all that care coordination between our agency and the other CBO and the health plan for the sake of the member, everything for the member. So it has been, but we definitely need consistency. My preference would be members' choice, If the member says they don't want to be part of that CBO, they'd rather be under Kitty's Community Care Hub or ours or directly, then so be it. That's how the other services are, and it shouldn't be any different.
Thank you. I believe we have time maybe for one or two more questions. This one says, beautiful points. What are the unintended consequences of increased workload on CHWs, and how do you all envision mitigating burnout?
I think there's a lot of unintended, I think that community health workers as a movement have been advocating for decades to be recognized as a billable service that can be provided in the communities, and that really shows that we value the work of community health workers and that the contribution that community health workers make to our shared goals around improving healthcare outcomes while reducing healthcare costs. I think that as soon as you get a win, you start to see what are the unintended consequences of that win. And that includes the medicalization of community health workers. It includes things like productivity requirements for community health workers, which I hardly ever use that word. I'm using it to show that it is an unintended consequence, because once you have billable visits, then you have productivity goals. And so I think it's imperative to really be listening to the CHWs themselves, to hear from them about what's working and not working, and have those solutions designed by community health workers. We've already seen the state do this in terms of removing the CHW certification program that HCI was going to implement, which was advocated for by CHWs. So I would really say we need spaces and times to really listen to CHWs and understand. I want to deeply admit that I don't understand what it's like to be a CHW day in and day out. So I don't know the solution. I need to be in listening mode and hearing from CHWs on what are those solutions to create jobs where they're thriving, they're making a living wage, and they're getting what they need so that they can serve the community, so we don't get burnout and compassion fatigue. We need to help in all of these ways.
I 100% agree with Kitty. Listen to them, understand, and pivot and shift to help them. Remember, these CHWs they're not USC graduates or anything like that. They grew up in they just have different experiences. And I could relate to that growing up myself. And we've noticed if agencies do not listen to them, you'll see a huge turnover. You'll lose them. But if you really match them and partner them up and specifically work on the training with them, a lot of them they need some additional time to train. You're training them to be, in essence, social workers. And we notice when they thrive, it's when we pair them up with participants that have similar experiences, family or community experiences. And that's when they really, really, really thrive. We also make sure that we avoid burnouts by allowing them different flexibilities at our workspace. So our staff are typically all remote. They could work from home, but we do have areas throughout the county for them to go and work from the office. A lot of them love that, especially during the heat. They may not have air conditioning. Some of them want to leave their families and just, I'm going to get away from dad or grandpa and just go work at the office. And we welcome that. But continuous training, continuing to listen to them. I think it's Kitty really nailed it. So I have nothing else to say.
Perfect. Well, thank you all so much. We are almost at time. Thank you to our speakers for sharing your insights, and for all of you joining this discussion. We hope you're leaving with a deeper understanding of CalAIM's direction and practical ideas to support your work. And we appreciate your time and your engagement. And we look forward to continuing this important conversation. Before you go, please complete this webinar poll. Thank you, everyone.